Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is May 20th, 2026, and I'm your skeptical host, Ken Milne. The title of today's podcast is I'd Like to Treat DKA with the SQuID protocol. And our guest skeptic is Dr. Matt McArthur. He is an emergency department physician working primarily in Guelph and Kitchener with the occasional rural locums in the small town where he grew up, Walkerton. His clinical interests include hocus pocus, emergency cardiology, QI, so quality improvement, knowledge translation, motivational interviewing, and vertigo. Wow, that's a whole mix of stuff there. He's very active in medical education, including a clinical skills and POCUS instructor and contributing editor with our good friend over at EMCases, Anton Hellman, and the regional education lead and undergraduate family medicine at Waterloo Regional Campus of McMaster University. Oh yes, that's the home of evidence-based medicine, at least from Canada. Hey, Matt, welcome to the SGEM.
Great to be here, Ken. Long-time listener, first time calling in.
Well, you did more than call in. You reached out to me with this updated SQuID protocol study that was published in Canada. You've been listening to the SGEM for a long time, have you?
Yeah, I for the last 2 or 3 years, I've been a huge FOMED podcast junkie. It started off with emergency medicine cases, which I now help out a little bit with. But then quickly I got into the SGEM and all these other sort of foam resources. And so, yeah, I've been listening to your podcast basically every week for a couple of years now.
Well, in true Canadian fashion, I'll say, well, sorry about that. But is there anything specific about FOMED? Like, what's the big deal? Why do you like FOMED? What does it bring to you as somebody who's out there, frontline practicing clinician? Why FOMED?
Well, Ken, I think that as a relatively new to practice clinician, I've always been wanting to bring the best possible care to my patients based on the best available evidence. And I would notice that, going through my training, some clinicians would do things different ways. And I would often ask, what's the best way of doing something? And as we know, there's a real delay in knowledge translation through conventional means. Textbooks take years and years to get updated. And FOMED allows us to better evolve our practice to meet the best evidence and provide the best care to our patients. And I think in the end, that's my passion, is just wanting to provide the best possible care to my patients.
I love that answer about giving great care, the best care to patients. And sometimes that means more care, sometimes that means less care, but it's about the right care based on the best evidence. And you've reminded me about the godfather. Oh yes, the godfather of FOMED, and that is Dr. Joe Lex. And Joe Lex, I don't know if you know this, Matt, but he was one of my mentors out there doing FOMED before we even had a term for FOMED. And he's famous for saying,
This is Dr. Joe Lex in Philadelphia. If you want to know how we practiced emergency medicine 5 years ago, read a textbook. If you want to know how we practiced emergency medicine 2 years ago, read a journal article. If you want to know how we practice emergency medicine now, go to a good conference. But if you want to know how we will practice emergency medicine in the future, listen to the conversations in the hallways and use phone. Take the hashtag, leave the classroom.
Oh, Joe Lex, we miss him. He's retired now. Great guy.
Yeah, absolutely.
All right, so we need to get on with a case, though. We could banter on about medical education and FOMED all morning. So give us a case.
All right. So for our case, we have a 56-year-old woman with insulin-treated type 2 diabetes. And she presents to the emergency department with 24 hours of nausea, vomiting, polyuria, and weakness after missing insulin doses during a viral illness. She's alert, mildly tachycardic, normotensive, breathing slightly fast, and appears dry but not toxic. Her labs show glucose of 23 millimoles per liter, pH of 7.26, bicarbonate of 14 millimoles per liter, an anion gap of 22, and positive serum ketones. You diagnose her with diabetic ketoacidosis. After initial IV fluids, she is clinically improved and does not require any vasopressors or airway support. The practical question is whether she really needs an intravenous insulin drip and intensive care unit level care, or whether a structured subcutaneous insulin pathway would be safe and effective.
Well, Matt, we have this international audience, so I really need to put a pin on something here. A glucose of 23, and people in the US are like, she's so hypoglycemic, but it's 23 millimoles per liter, which for our American friends is about 414 milligrams per deciliter. Now, in Canada, our normal range for glucose is around 4 to 7, and that translates into a normal glucose, if you're using milligrams per deciliter, is about 70 to 130. So she is hyperglycemic, acidotic, got a gap, DKA, right? But that glucose, I don't want people to gloss over the fact that she has a glucose of 23 millimoles per liter. Well, DKA, it is one of the classic endocrine emergencies that, boom, that lands squarely in our wheelhouse in emergency medicine. And it's a state of insulin deficiency. We know this, right? But it leads to this progressive dehydration with the nausea and the vomiting. Electrolytes go off. People get acidemic. And, when put all together, it can be fatal if untreated. And clinically, these patients show up dry. They've got polyuria, polydipsia, nausea, vomiting, abdominal pain, tachypnic, or even Kussmaul respirations, and that dehydration, and sometimes altered mental state.
Yeah, and since the discovery of insulin by Frederick Banting in Toronto in 1921, so great Canadian representation there, the treatment of DKA has changed dramatically in the last 100 years. Prior to insulin, the mortality of DKA was thought to exceed 95%. And in modern times, the mortality is way down. It's actually less than 1%. So we've seen incredible gains in the last 100 years of treatment of DKA.
And it's interesting how everybody loves to claim people that are successful. So in London, Banting, we have a Banting High School. James Collop, who was also part of that discovery. I went to undergrad at Western University, where we had a James Collop building. And of course, we don't want to forget the best guy, Charles Best. And as a reminder, very Canadian, they sold the patent for insulin to the University of Toronto for $1. Now, I don't know if that was an American dollar or a loonie, but they sold it for $1 in January 1923. And Sir Frederick Banting famously stated that, quote, insulin does not belong to me. It belongs to the world.
That's inspiring and refreshing. And he's right in a sense. It is an endogenous peptide hormone, but by being able to create it, he was able to revolutionize care for these patients who prior to that did not have a treatment.
And died. Those type 1 diabetics, they died. Their life expectancy was significantly shortened. So changed the world with a peptide. And now the peptide is all the big rage with wellness influencers, but that's a whole nother podcast.
Yeah.
DKA treatment involves protocolized based care. Usually, typically starting with IV hydration, when we recognize it, because there's been a few cases, especially with younger children that presented with nausea and vomiting, thinking maybe gastroenteritis with their diarrhea and thinking, this is just your straight up gastroenteritis. And it turns out to be a first presentation of DKA. But they can be hypovolemic, and insulin therapy comes to stop the ketoacidosis and restore normal metabolism. You've got to worry about their electrolytes. You got to start replacing dextrose and correct these deficits. And then you've got to really monitor these patients for their glucose and their electrolytes, especially you can't forget that potassium, right? So you got to watch that potassium all during their treatment course.
Yeah, absolutely. And DKA is not something that corrects immediately. You can't give insulin and expect them to be totally back to normal in an hour. It takes time for DKA to correct and those treatments to kick in. Most hospitals, as a result, have labor-intensive DKA protocols, including IV insulin infusion, which often require patients to be admitted to ICU due to high nursing demands of these protocols. However, with the introduction of rapid-acting subcutaneous insulin analogs in the late 1990s, such as insulin Lispro and Aspart, some clinicians have evaluated the use of rapid-acting subcutaneous insulin boluses as an alternative to IV infusion.
Yeah, and the SGEM's already dipped its toe in these waters. See what I did there with the SQuID protocol? Mm-hmm. We've dipped our toes into these waters on SGEM511, which covered the SQuID protocol. And in that episode, we asked whether adults with mild to moderate DKA could be treated with fast-acting sub-Q insulin in a non-ICU setting, resulting in shorter ED lengths of stay. And that study by Griffey et al. In AEM highlighted the operational appeal of avoiding insulin drips in an ICU stay for every uncomplicated DKA patient.
Yeah, and between 2004 and 2016, there were 6 small randomized controlled trials which found equivalent safety between subcutaneous insulin boluses and IV infusion in adults. Given this safety evidence, and out of a desire to provide more efficient DKA care and avoid unnecessary ICU admissions, some hospitals, like the Griffey Group, have designed and implemented subcutaneous insulin-based treatment protocols as a first-line option for uncomplicated DKA patients. And these hospitals have published their outcomes in the medical literature in many cases.
Yeah, in addition to those 6 small RCTs, in the last 5 years, we've seen several observational studies published reporting patients and operational outcomes after implementing a hospital-wide subcutaneous DKA protocol. And in those observational studies, that included the SQuID-1 by Griffey et al., but that means there must have been a SQuID-2, and there was a SQuID-2, which further provided outcomes in the same hospital in St. Louis.
And then when we look through the literature over the last few years, we've also seen Rao in 2022 report on a protocol they introduced at Kaiser Permanente San Jose. We've also seen Stewart et al. In 2023 publish their protocol that they implemented in Utah. And then Qiang et al., apologies if I'm mispronouncing that, in 2025 published their outcomes that were from their protocol in Toronto. And then in 2026, we've seen Ibarra et al. Publish their protocol, which was implemented in Fresno, California. So we've seen lots of different hospitals all over North America that have been implementing protocols and sharing their outcomes with the world. There were also diabetes consensus guidelines published in 2024, international, European, and North American, that endorse the use of subcutaneous insulin in DKA.
All right, so Matt, what's the clinical question we're going to try to answer today?
So the question for this study is, in non-pregnant adults with mild to moderate DKA, is subcutaneous insulin a safe and effective alternative to IV insulin for DKA management?
All right, and what's the reference for this?
The reference is Qiang et al., Safety and Effectiveness of Subcutaneous Insulin for Management of Mild to Moderate Diabetic Ketoacidosis in Non-Pregnant Patients, a retrospective cohort study at a tertiary care center. That's a long title. This is in the Canadian Journal of Diabetes in October 2025.
Maybe it's just forecasting how long it took them to turn around the DKA in this study. Ooh, I'm hinting at something. All right, let's go through the PCOT. What was the population?
The population is non-pregnant adults aged 18 years or older, admitted with mild or moderate DKA, as defined as an elevated urinary or serum ketones, plus at least 2 of pH of less than 7.3, bicarbonate below the lower limit of normal, ANAN gap of greater than 12 millimoles per liter, or glucose greater than 14 millimoles per liter. Again, that's Canadian/international units. And euglycemic DKA was included in this study, and that could have a relatively normal glucose.
And then they had a number of exclusion criteria, and I'll throw them up in the show notes, but let's get to the intervention. And in this case, it was an exposure because they had introduced a new protocol. What was the exposure in this case?
So the exposure was patients who were put on the subcutaneous insulin protocol that the hospital had just introduced. And this protocol is glargine, 0.3 units per kilogram, or the patient's home dose. So they are upfront giving a dose of long-acting, plus aspart, so a short-acting insulin, dosed at 0.2 units per kilogram every 4 hours until the glucose fell below 14 millimoles per liter, with glucose checks every 2 to 4 hours and electrolytes and blood gas every 4 hours. And then fluids and replacement for electrolytes and glucose was ordered per treating physician.
All right, and what did they compare it to?
They compared it to their standard IV insulin treatment protocol.
All right, let's run through their outcomes. What was their primary outcome of interest?
There were 2 primary outcomes, and I know we often prefer just one primary outcome, but these outcomes were time to anion gap closure and hospital length of stay.
Oh, co-primary outcomes. Or you could read that as 2 primary outcomes. So typically I state the Princess Bride quote, primary.
I don't think it means what you think it means.
Or you could go to Highlander from the 1980s.
There can be only one
primary outcome. Okay, how about their secondary outcomes?
So their secondary outcomes were hypoglycemia, hypokalemia, and anion gap acidosis requiring intervention within 24 hours.
So a whole bunch of lab-oriented outcomes. What type of study was this?
This was a retrospective cohort study.
All right, the author's conclusions were, quote, "These results suggest that subcutaneous insulin is safe, although it may take 8.4 hours longer to close the anion gap with subcutaneous insulin. There is less hypoglycemia and hypokalemia and no difference in length of stay in the hospital." End of quote. Well, let's go through the quality checklist for observational studies. Matt, did this study address a clearly focused issue?
Yes. The study hospital implemented a new subcutaneous DKA protocol in 2022, and the objective of their study was to retrospectively look back and compare outcomes of patients who got the subcutaneous protocol compared to those who got the IV protocol during the same time frame to evaluate the feasibility and safety of the protocol.
Do you think that the authors use an appropriate method to answer their question?
I would say yes. A retrospective cohort is an appropriate way to evaluate outcomes after implementing a new hospital protocol.
Did they recruit the patients in an acceptable way?
Again, I think so. They retrospectively identified charts for DKA patients using ICD-10 codes, and they used an independent chart review by 2 separate physicians of all of the charts that they identified.
And was the exposure accurately measured to minimize bias?
I think it was, most likely. So treatment was documented in the chart and reviewed by 2 separate physicians, and only 11 charts, so 4.8%, were excluded due to incomplete data, and 6 charts were excluded due to incomplete treatment.
And how about the outcome? Was it accurately measured to minimize bias?
I'm unsure about this. The time to closure of the anion gap is based on blood work, which was ordered per protocol for all patients admitted with DKA. They don't tell us if, in practice, blood work was done more frequently in the IV group, which could bias towards earlier detection of anion gap closure.
Yeah, you don't know if you close the gap unless you got the blood work, and if you got the blood work quicker, like in that 2 to 4 hour range, if you were more towards the 2 hours, obviously you could show that it closed quicker if you ordered blood work more frequently. Mm-hmm. How about the authors? Do you think they've identified all important confounding factors?
I would say the answer is clearly no for this. There are just many possible confounders that cannot be captured with this type of study design. Since it was up to the physician's discretion, there may be unmeasured provider and patient factors that influence which patients received IV and which received subcutaneous. Additionally, patients may have been treated differently by nursing and inpatient teams depending on the protocol they were on, in ways that are just impossible to account for in a retrospective chart review.
And was the follow-up of subjects complete enough?
Yes. Very few charts were excluded due to incomplete data or treatment.
And how precise did you find the results?
Unsure. Precision is reasonable for time to anion gap closure and hypokalemia, but limited for rarer safety outcomes, and especially for the euglycemic subgroup.
Well, do you believe the results?
Yes, I do.
And can the results be applied to your local population in Guelph and Kitchener?
Unsure about this. The applicability depends heavily on local nursing ratios, lab turnaround, monitoring capability, and more importantly, whether your site has a structured protocol. So at the places that I work, we don't yet have a subcutaneous protocol for DKA treatment, but I do think we can use this information as well as others from other hospitals that have used subcutaneous insulin to potentially one day implement it in the future.
Well, maybe you can bring this up through the proper channels at Guelph and Kitchener to see if you can implement a subcutaneous insulin protocol, and you can tag this podcast for them to listen to consider whether or not they want to do this.
Absolutely. Yeah, I think that'll be in the works for sure.
All right. Do the results of this study fit with the other available evidence?
This is definitely a yes. Multiple other hospitals, which we listed in the intro, have also shown safety and efficacy of subcutaneous insulin protocols in the last 5 years when they also implemented subcutaneous insulin.
And where did the funding come from for this study?
It was supported by a quality improvement grant from Banting and Best Diabetes Center, Innovative Diabetes.
And did the authors declare any conflicts of interest?
None were declared.
All right, let's get on to the results section and summarize sort of the demographics. Who are these people? What did they include in the cohort? And they had 153 admissions with 92 on IV insulin and 61 on subcutaneous insulin. The mean age was middle-aged, about 57 in both groups. Oh my gosh, I'm above middle age now. I'm above average. Women made up 53% of the IV group and 54% of the subcutaneous group. Now, this is interesting. Type 2 diabetes predominated about 2/3 of their patients. 2/3. I want to really emphasize this. 2/3 of these people in a DKA study were type 2 diabetics, with only 1/3 being type 1 diabetics. And then the euglycemic DKA was present in about 24% of the IV treated patients and 16% of the sub-Q treated patients. When you look at the IV group, comparing the IV group to the subcutaneous group, they appeared sicker at baseline, suggesting maybe some intervention was differently applied to that group because they appeared sicker with more moderate DKA versus mild DKA, more renal dysfunction, and more neurologic dysfunction. And about 30% of the cohort was taking an SGLT2 inhibitor. All right, Matt, that's a lot of demographics. What was the key result? What did they find?
The key result is that IV insulin closed the anion gap more quickly, but subcutaneous insulin caused less hypoglycemia and hypokalemia, with no meaningful difference in hospital length of stay or in anion gap reopening requiring intervention.
Hey, Matt, has any patient come to you and said, "Hey, doc, how long did it take my gap to close?" Did they ever bring that up with you in your years of experience?
No, I can't say I've been asked that particular question.
Yeah, I haven't had that question in over 30 years. Hey, doc, how long did it take for my gap to close? All right, let's drill into the numbers a bit, though. What was the primary outcome?
So the primary outcome is IV insulin was faster to close the anion gap. Adjusted median 15.6 hours versus 24.0 hours for subcutaneous, with an adjusted hazard ratio of 0.65. And the 95% confidence interval was 0.45 to 0.92, with a p-value of 0.02.
So you could close the gap about 8 hours quicker with IV insulin. When you looked back at this population. There was no statistical difference in hospital length of stay, though, and so I will put the exact numbers up in the show notes. Were there any secondary outcomes that you really thought we should highlight?
I think that, again, we already have to recognize that there are limitations to a retrospective study design, lots and lots of confounding, that we have to take these secondary outcomes with a massive grain of salt. Ironically, hypokalemia, maybe they should have been getting some potassium salt.
Oh, I see what you did there. You're not a dad yet, are you? That was a bit of a dad joke.
Yeah, I'm working on it. Working on my dad joke game. I'm an unk,
Okay, it was an unk joke.
Group, that's what I'd be called in my sort of age group. Yeah, so hypokalemia and hypoglycemia were a couple of the secondary outcomes. And there was a higher incidence of both of those in the IV insulin treated group. Again, though, take that with a grain of salt based on the study design.
Yeah, if you looked at the difference, the actual difference was about 20% actual difference. So 1 in 5 in the insulin group got hypoglycemic and hypokalemic compared to the subcutaneous insulin group. But we'll put a table in the show notes for anybody who wants to drill into the secondary outcomes. And you're right, we really should be more skeptical of secondary outcomes, maybe hypothesis generating and stuff like that. But certainly in an observational study that's retrospective and a secondary outcome, interesting, but we would need way more information to base our clinical decisions based on those things. But hey, you've come to the favorite part of the SGEM, and that's where we get to talk nerdy. And you suggested 5 different things, and I suggested 5 different things, and I tried to mash them up together so we could have 5 different things. But at the end of the day, you know what? The things that you suggested were really good to talk about. And so we're going to do 2 sets of 5, just so I can stick with my 5 things. And so I'll go first if that's okay, Matt, and then you can follow with your 5 things. Is that okay?
Oh, absolutely. And I think, we've got some overlap in the points we wanted to talk about, so we can just kind of play off of each other a bit.
We'll just alternate. All right. So the first thing is confounding by indication. Treatment was not randomized, and the treating physicians chose, hey, that person's going to get IV, whereas this person's going to get sub-Q. And in a cohort study, the exposed and comparison groups should have the same prognosis if we really want to minimize bias estimate of effect. And here, the IV group was clearly sicker at baseline, more moderate DKA, more renal dysfunction, more neurologic dysfunction. And, you can do multivariable adjustments. That'll help. But there's no regression model that can fully remove bias from unmeasured or poorly measured prognostic differences in a retrospective cohort study.
And building off of that point, I think the first thing that we have to think about when we look at this study is this is a hospital implementation study. So it really falls under the kind of scope of QI or quality improvement. So in evidence-based medicine, we love randomized controlled trials, RCTs, and that's what we're used to talking about. We're used to talking about evidence in that sort of lens. And we have to apply a very different lens because this is not an RCT. This is a hospital that did a quality improvement project and is now looking back on their results. And quality improvement is a very iterative process. Hospitals are often doing things, reevaluating their outcomes, changing and adapting. And so we have to take this information for what it is, which is essentially that in this study, a new subcutaneous insulin protocol was introduced in the Sunnybrook Hospital in Toronto in 2022. And then the authors performed a retrospective chart review to look at the patient outcomes after they adopted the protocol. But obviously how things rolled out in their hospital in 2022, which was during COVID times, might be quite different than your hospital in 2026 or in other hospitals that have also reported their outcomes after DKA protocol implementation. We can learn a lot from observational studies of other hospitals' treatment protocols, but we should be just skeptical of the external validity to other practice settings and recognize that if you're designing a hospital protocol for your own hospital, it might be a little different than Sunnybrook in Toronto, depending on where you work. The bigger point here is that there are about 5 small RCTs comparing IV and rapid-acting subcutaneous insulin in DKA that were published between 2004 and 2015. And they all show good safety and efficacy of insulin subcutaneous, although they are small studies. They're not these large, high-quality studies that we like to see. But despite these being small studies, expert consensus and clinical practice guidelines have broadly endorsed the use of subcutaneous insulin in DKA. So many hospitals like Sunnybrook and many others have already rolled out subcutaneous protocols as a standard therapy, not an experimental therapy. And so as a result, most of the new papers we're seeing, like the SQuID protocol by Griffey, like this paper, are not RCTs, but observational studies that are just reporting on outcomes after the hospital implements a new protocol. And I think the takeaway from all of this is that if you were dissatisfied with these small RCTs already out there, and we're hoping to see a big, high-quality, multi-center RCT comparing subcutaneous and IV insulin, unfortunately, the cat is probably already out of the bag, and we're unlikely to see many more RCTs on this topic because hospitals and clinical practice guidelines are already rolling this out as a standard care.
Yeah, and we really need to be careful about, looking at small RCTs because RCTs are usually powered for efficacy, not safety. And so we have to be cautious about safety because safety, as a general comment, is systematically underreported. And also the studies aren't powered for safety and they're not powered for rarer events. And so that might not show up until widely implemented in larger observational studies.
Absolutely.
All right, let's talk about my number 2, and that's co-intervention imbalances. The groups differed not only by the insulin route, but also in important aspects of care. The IV group received more dextrose infusions, more normal saline, more potassium supplementation, and was more often kept NPO. In observational studies, these accompanying management differences can act as confounders, especially when the outcomes themselves, like you're looking at, hypoglycemia, hypokalemia, and even length of stay, are plausibly affected by how much fluid did you give? Did you give dextrose? How about your electrolyte strategies? And it's not just isolated on that one dichotomous thing, insulin route of administration.
Absolutely, Ken. I think the key with DKA treatment is it's not just insulin. It's a whole protocol that involves monitoring, that involves fluids, that involves replacement. And so if you are trying to simply hinge the entire outcomes on insulin, you're neglecting that there could be other important differences in the protocol that are influencing patient outcomes. And as you mentioned, those specific protocols or parts of the protocol were actually done quite differently in the different groups in this study. Now, another point that I wanted to draw attention to is the possible false dichotomy between subcutaneous and IV insulin, which I think this is something we broadly deal with in medicine. If you've ever listened to Justin Morgenstern talk about oral antibiotics, I think you'll know what I'm talking about here. But lots of studies comparing IV to other forms of treatment will use language that creates possibly a false dichotomy, as though the route of administration is the single determining factor on how the drug works, when the reality physiologically is far more nuanced. So when you think about it, IV and subcutaneous insulin are both systemic therapies. Think about it, subcutaneous insulin doesn't work by staying in the skin. It works by going into the bloodstream, much like IV therapy. And we know that a rapid-acting subcutaneous insulin takes about 20 minutes or so to be absorbed and reach therapeutic levels in the bloodstream. But it's still going the exact same place, which is the bloodstream. And so when you realize that both of these therapies are systemic therapies, the false dichotomy, in my opinion, falls apart rather quickly. Much more important, I think, than the route of administration is actually the dosing and frequency, which will dictate the serum insulin levels at any given time. So as a very basic hypothetical example, if a patient receives IV insulin infusion at a rate of 5 units per hour, the patient is receiving half the insulin as a patient receiving subcutaneous insulin at 20 units administered every 2 hours, but an equal amount of insulin as a patient receiving subcutaneous insulin at 20 units every 4 hours. So really, we can kind of conceptualize it as how many units of insulin are they getting per hour, because it's all going into the same place, which is their bloodstream. But the systemic levels will be determined by the dosing and the frequency. And I think this is important because we have several studies of subcutaneous protocols that use different dosing and frequency. So it's not like Rao over in Kaiser Permanente is using the exact same dosing as Qiang in Sunnybrook, which is using a different dosing and frequency than Griffey in St. Louis. So there isn't a single universal way to give subcutaneous insulin. And the exact same thing is true for IV insulin. Some protocols have an upfront IV bolus, others do not. Some use different infusion rates. So the bottom line for this is, rather than just dichotomizing subcutaneous or IV, we should also consider the number of units of insulin per hour that a patient is receiving based on dosing and frequency that is used.
Matt, I'm going to push back gently. I'm glad you put possible false dichotomy. I really enjoy talking about fallacies and logical fallacies. A false dichotomy would be considered an informal logical fallacy, which takes context and nuance. And as my EBM mentor, Andrew Worster from McMaster University always said, the answer is it all depends. And so when you look at this as a false dichotomy, it really does depend on what you consider a dichotomization. So subcutaneous insulin, it's slower on onset. It has intermittent absorption, longer effect, doesn't typically require an ICU up until some of these new protocols, and its effects persist. Now, in contrast, if you're doing IV insulin, it could be argued that it is a true dichotomy because it's much more immediate action of onset. It can be continuously titrated, even minute to minute. You can dial it in. It's more predictable and bioavailable than doing subcutaneous. Very short-acting half-life. Usually requires an ICU admission. And it's easier to rapidly stop. You can turn off the infusion. You can't turn off the subcutaneous injection if you have an episode of hypoglycemia. So I will leave it up to the audience to decide, do they think that this is a true dichotomy or a false dichotomy of sub-Q versus IV insulin? Do you have any thoughts on that?
I mean, I do have some thoughts, and I would say that when you actually look at data that we do have in terms of the pharmacodynamics of insulin, it's not this rapid on, rapid off medication the way norepinephrine is, for example. So if you adjust your norepi drip, it's immediately within 2 minutes, you're going to see their blood pressure change. If you adjust someone's insulin drip, it's going to take 30 minutes for the systemic effects of the insulin to start taking place, and it's going to take an even longer time for it to reach a new steady state. If you shut off someone's insulin drip, the effects of insulin are still going to be around for up to 5 hours. So it's not a rapid on, rapid off the way norepinephrine is. From my understanding of looking at the pharmacologic data from sources like UpToDate LexiDrug.
So I guess it depends on how you define rapid and turning on and off, because clearly it's not, insulin is not norepinephrine. I agree with you on that. Anyways, let's get on to the third thing, and that is detection bias. This paper notes that electrolytes and venous blood gases were measured every 4 hours in the subcutaneous group, whereas the IV group, the physicians could check them every 2 or 4 hours. And if the IV group is checked more often, the time to biochemical resolution, in other words, closing that gap, can look better simply because there are more chances to catch the first normal anion gap. And this is classic detection bias.
Yeah, Ken, I absolutely agree with this point. And it's something I noticed about the paper as well, particularly when you think of, as you already mentioned, in general, the patients who were put on the IV protocol were sicker to begin with. So probably, and then probably the fact that they were put on an IV protocol, the team was also probably more aggressive with blood work, more aggressive with rechecking. And as you mentioned, other parts of the protocol also differed. In terms of, were these patients receiving supplemental dextrose and potassium and so forth. So I think this certainly would introduce bias into the results of this study.
All right, you had a third point, and this was about DKA treatment is more than just insulin, but we've covered that multiple times, so we'll leave those thoughts up in the show notes. But I'm going to jump on to my fourth point, and I love talking about the POO, but this is about precision and POO, or patient-oriented outcomes. The total sample was modest at 153 patients, which can lead to a wide 95% confidence interval around the point estimate. The euglycemic DKA subgroup was small, 32 patients. So rare harms and subgroup findings are really unstable. I have a table in the show notes that show the outcome itself for these euglycemic patients with anion gap closure, length of stay, and hypokalemia. And you can see the point estimates, but what I really want people to focus in on is look at how wide the confidence intervals, those 95% confidence intervals around the point estimate. I mean, the one for hypokalemia goes from 0.15 all the way up to 0.8. And so that's wide. In addition, anion gap closure is a lab-oriented outcome, a LU, or you could consider it a DO, a disease-oriented outcome. But it's not a POO. It's not a patient-oriented outcome. Now, hospital length of stay is patient important, but it's also heavily influenced by bed availability. Do we have a bed in the system? How that actual system operates. And so the study gives us useful operational and safety signals, but it's certainly not the last word on clinical importance of effectiveness.
My fourth nerdy point, building off of kind of these discussions around anion gap closures, which was one of the outcomes they're reporting, is what actually is the definition of anion gap closure? And this is something I found quite interesting because I also went and read studies by Rao, Griffey, Stewart, and Ibarra, which are all United States hospitals that implemented subcutaneous protocols. And for all of these studies, they are actually using an anion gap cutoff of less than 16 to define anion gap closure. And for Qiang et al., in this study, they're defining anion gap as an anion gap of less than 12. And so naturally, that's going to change how long it takes for anion gap closure to be obtained, depending on how you actually define anion gap closure. This is just something I found kind of interesting. It's not something I had thought a lot about before looking at this study and comparing it to some of the other studies. But for me as an emergency provider, if I am treating a patient who doesn't have DKA, say, but may just be coming in with gastro or viral illness, and the anion gap is 13 or 14, I usually don't even think about it because I know what's going on with the patient and I'm not worried about it. And so I find it interesting that they used a much more conservative anion gap compared to some of the other studies that have been published on this topic.
So I'll try to relate to you outside of the 1980s. Are you familiar with a show called Reacher?
I can't say that I've seen that show, no.
Oh, no. Jack Reacher. He's a loner investigator, drifter who used to serve in the U.S. military in their investigations department. And he has a saying, in investigations, details matter. And in research, details matter. And the detail here that you just learned about was the definition. And that's why it's so important. How did they define an anion gap? And if that closure had to be less than 12, clearly it's going to take longer to get to less than 12 than it takes to get to less than 16. And we see this in other literature, and I don't want to bring up the stroke literature, but here we go. In the stroke literature, they define good neurologic outcome. Is that a modified Rankin scale of 0 to 1? 0 to 2. In some of the bleeding intracranial hemorrhage literature, it's 0 to 3 is considered a good outcome. So you want to be making sure that you define those outcomes so you can compare apples to apples. And you picked up something there with the definition of anion gap closure, which could explain their length of stays. And so this gets into my fifth nerdy point, and this is about external validity. This was a single center tertiary Canadian study. This was Sunnybrook. This is one of the shining examples of, hospitals in Canada, Sunnybrook. And it was conducted in their emergency department because patients presented there, but their intensive care unit, because these people were not sent to the general wards because during the time period in 2022, they felt that the nursing ratios, the patient to nursing ratios were inadequate for the protocolized monitoring they wanted to use. And so all of these patients, and I really think this is important for people to understand, all of these people were treated in a higher acuity environment. And there's a difference. These are ICUs rather than on the general ward. And if you've been into the ICU, they're different than your general medical ward. And you can get excellent care in both, but the expectations and the resources are different. And so all of these patients at this single center, tertiary or quaternary study done in Canada, these patients were managed in an intensive care unit setting. And then, of course, there were these exclusions, pregnant patients, which we've talked about before being a problem with exclusions. And then I listed in the show notes the other exclusions. And so this makes the results from this study, from this quality improvement or retrospective analysis of when they implemented this new protocol, it really makes it applicable to this selected, stable, not pregnant, uncomplicated adults in a well-resourced ICU quaternary care setting with robust monitoring.
Absolutely. And that certainly may not be applicable in different sites, depending where you work.
You work rural.
Yeah, I do.
You work in Walkerton. Do they have that kind of setting in Walkerton, a primary care hospital or a secondary center as opposed to a tertiary or quaternary center? There's differences between rural and urban.
100%. And the last point that I wanted to make that's kind of a nerdy point, because I've been looking at other implementation studies where other hospitals, mostly U.S. hospitals, have implemented a new DKA protocol with subcutaneous insulin. And one of the things that I noticed was there's a pretty major difference for Qiang et al. In terms of DKA length of stay compared to most of the other hospitals that have published their outcomes from subcutaneous insulin. And so specifically, I'm talking about Rao in San Jose in 2022, Griffey in St. Louis in 2023 and 2024, Stewart in Utah in 2023, and Ibarra in California in 2026. Really, the Sunnybrook patients, their length of stay was a lot longer. And I wondered, why is that? And I think what I'd like to get into is that there's very big differences in the patient population that they were treating compared to these other hospitals who also released subcutaneous protocols. I think an important point is that when we think about subcutaneous protocols for DKA, well, why are we implementing them in the first place? And the reason is, by and large, we know that patients coming into the hospital who have uncomplicated, mild to moderate DKA will do well. Nobody is expecting a patient with mild or moderate DKA who's not complicated. No one's expecting that patient to die during their hospitalization. In fact, if that patient dies, something probably went horribly wrong. So we know these patients are going to do well because mild to moderate DKA is a very treatable condition with a low mortality rate. But practically speaking, the reason we would implement subcutaneous DKA protocols would be to take this group of patients who we already know they're going to do well and make their care more efficient and streamlined and less resource intensive. Because traditional IV protocols, though we know that they're effective, are quite cumbersome and often require patients to be on a drip and admitted to ICU with a lot of monitoring. So for all DKA hospitalizations, Rao et al. Reported a 57% reduction in ICU admissions compared to control sites after implementing their subcutaneous protocol with equivalent length of stay and safety, as well as a 50% reduction in hospital readmission after implementing the protocol. In 2024, Griffey reported they had achieved a 33% absolute reduction in ICU admissions for mild to moderate DKA, with a length of stay of 47 hours for subcutaneous protocol patients compared to 102 hours for IV protocol patients and no difference in safety outcomes. And then another interesting study was Ibarra in 2026, which reported on a subcutaneous insulin protocol that they implemented in an ED observation unit that's specifically designed for patients who need ED level of care with reversible problems, with the goal of treating and discharging them within 24 hours. And using this approach, they managed to achieve a median hospital length of stay of just 19.6 hours for DKA patients admitted under the subcutaneous protocol. And unlike these other hospitals, Qiang et al. In Sunnybrook still admitted their subcutaneous DKA patients to the ICU rather than a medical or obs ward, and their patient population was very different from those of the other patients, or of the other papers, I should say, which I think is what is driving these differences in terms of length of stay and ICU admission rates. And the biggest patient-level difference that jumps out is that the DKA patients receiving subcutaneous insulin in Sunnybrook are much older than those that other hospitals have published subcutaneous treatment protocols for. So the average patient age in the Sunnybrook cohort was 57 compared to the low 30s and low 40s in other studies. There was also a higher prevalence, a much higher prevalence, in fact, of type 2 diabetes of 69%, where the type 2 diabetes prevalence ranged in the 30s and 40s in other studies. So this suggests that the Sunnybrook DKA patients who received this protocol are generally older and likely much more complex than those in other hospitals' subcutaneous implementation studies. Not only that, but we know from a pathophysiology perspective that type 2 diabetes is very different than type 1 diabetes. And type 2 diabetes is often defined by insulin resistance. In other words, patients take a lot bigger doses of insulin to actually respond and to turn around, compared to patients with type 1 where there's less insulin resistance. So that might partly explain why the time to anion gap closure and the total length of stay was much longer in this study than in other retrospective studies we have of DKA protocols. And specifically, after implementing their protocol, the Kaiser Permanente group reported a mean hospital length of stay of 56 hours. Griffey et al. In St. Louis reported a hospital length of stay of 47 hours for their subcutaneous DKA. I talked about Ibarra and Fresno, who had a super quick length of stay of just 19.6 hours. And for comparison, the Sunnybrook mean length of stay was 168 hours. So ultimately, older, more complex patients probably played a major role in making the Sunnybrook length of stay a lot longer than the other hospitals that have shared their subcutaneous DKA outcomes. So we're still seeing safety, and we're still seeing kind of pretty equivalent outcomes in the different hospitals that have tried it, but we're seeing that the Toronto group have a much different population of DKA patients, older with type 2 diabetes, which probably represents the changing demographics of diabetes in Canada based on Toronto's aging population. But we can also expect that they're going to respond very differently than your typical 30-year-old with type 1 diabetes who missed a few insulin doses. And that patient's going to turn around a lot faster than a type 2 diabetic who's 57 and has some comorbidities. And so ultimately, I just wanted to draw attention that we have a lot of different studies where hospitals have implemented subcutaneous insulin protocols. And this study is quite unique in that it's looking at a much older population who has longer length of stays.
Well, you were nice enough to put together a couple of tables looking and comparing those different studies, the 1, 2, 3, 4, 5 different studies, looking at their insulin frequency, their ages, how many had type 2 diabetes, what was the time to closure for their gap, time to closure for their gap with IV versus sub-Q, and then their hospital length of stay, IV and sub-Q. And so I'll put those in the show notes with the table showing, their initial blood gases, initial gap, pH, and bicarb. So people can see whether we're really comparing apples to apples or apples to oranges here. But that's enough nerdiness. I can't believe I said that because I love talking nerdy. But it's time to comment on the author's conclusions and compare them to the SGEM's conclusions.
We agree with the authors that rapid-acting subcutaneous insulin boluses, as an alternative to IV insulin infusion, seem a safe and effective treatment option for adult patients with mild to moderate DKA. The author's other conclusions regarding length of stay and time to anion gap closure, as well as the risks of hypoglycemia and hypokalemia, are likely to be very specific to the hospital, patient, protocol, and provider factors in this retrospective implementation study and are not generalizable to other settings. For instance, in this study, the mild to moderate DKA patients who received subcutaneous insulin had a longer time to anion gap closure than those who received IV insulin. But in the SQuID-2 study by Griffey in 2024, the mild to moderate DKA patients who received subcutaneous insulin had a shorter time to anion gap closure than those who received IV insulin. So those other outcomes are probably a lot more specific to this specific hospital setting and not generalizable because it's not consistent with what we see in other settings.
Can you give us an SGEM bottom line?
Rapid-acting subcutaneous insulin is a reasonable alternative to IV insulin infusion for the treatment of mild to moderate adult DKA in hospitals with appropriate resources.
And can you resolve the case that you presented with that 56-year-old woman who presented with type 2 diabetes in DKA?
For the 56-year-old woman in the case, I would not automatically default to an ICU bed and IV insulin just because the diagnosis is DKA. If she remains alert, hemodynamically stable, and clearly has mild to moderate hyperglycemic DKA without shock, no concerning comorbidities requiring ICU-level care, and more importantly, your site has a protocolized subcutaneous pathway with frequent glucose and lab monitoring and potassium oversight, in this case, a subcutaneous insulin strategy would be totally reasonable. But if your department lacks that infrastructure, or if she drifts towards severe DKA, if she's starting to look really sick, if she has altered mentation, or there's some diagnostic uncertainty, I would stick with traditional IV insulin and the ICU monitored care.
So how do you think emergency physicians should apply this new study?
Emergency physicians should consider this study as another supportive paper for subcutaneous insulin treatment. It makes sense to consider this management for selected adults with mild, uncomplicated DKA who are non-pregnant, awake, hemodynamically stable, and able to receive frequent nursing assessment, point-of-care glucose checks, repeat electrolytes, potassium replacement, and a standardized basal plus rapid-acting insulin protocol. This is especially attractive in systems where IV insulin automatically triggers ICU admission or prolonged ED boarding. But IV insulin should definitely remain the default for severe DKA, altered mental status, shock, pregnancy, major comorbidity, need for surgery, unreliable monitoring environments, and probably for many cases of euglycemic DKA until stronger data arrive.
So how are you going to explain this new protocol to a patient who's just presented with DKA?
I would tell the patient, you have diabetic ketoacidosis, also called DKA. This happens when your body does not have enough insulin. Your blood sugar becomes very high, and because your body can't actually use that sugar without insulin, your body starts making acids called ketones as an alternate energy source. This can cause dehydration and lead to an imbalance in the salts and acid levels in your body. DKA can be dangerous if left untreated. Treatment for DKA includes IV fluids to help with the dehydration and insulin to bring your blood sugar and body chemistry back to normal. We will need to check your blood sugar and lab tests often while you are being treated. This means we admit you to the intensive care unit, ICU, for close monitoring. Even with good treatment, DKA can take many hours to get better. Some hospitals use subcutaneous insulin injections instead of an insulin drip for certain patients with mild and moderate DKA. These treatments may work just as well in some people and help avoid an ICU stay. Our hospital may use this type of treatment in the future, but right now we use the IV insulin drip and ICU monitoring for patients like you.
It is now time to announce the Keener contest winner, and Dr. Stephen Stelz won again. He's from New Zealand, and he knew two of the most common consumed coffee species worldwide are coffee araberic and coffee canephora. What's the question this week?
What three core features define DKA in the 2024 consensus report?
And if you know that answer, then just send me an email, thesgem@gmail.com, with Keener in the subject line. The first correct answer will get a shout out on the next episode. Matt, I wanted to put in a bonus question of why Canada and much of the rest of the world uses millimoles per liter, while the U.S. uses milligrams per deciliter. So as a bonus, if you know the reason, come on, America, if you know the reason why most of the world is using millimoles per liter, while the U.S. and a few other countries are using the milligrams per deciliter, send me that too, because I'll give you a shout out. Anyways, thanks, Matt, for coming on the show.
Absolutely. Yeah, it's been my pleasure. I would be happy to do this again sometime.
Oh, let's collaborate again in the future. I love talking nerdy with other rural emergency physicians.
Absolutely.
Until we get together, can you read the SGEM tagline?
For sure. So, remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next week.
The gap is closed, now home they go.